Good morning, good afternoon, good night, wherever you are. My name is Lorenzo Alonso. I'm from the Foro Oslo Association, a medical organization devoted to improve clinical reasoning and medical practice in general. Today, celebrating the Cancer Day, I would like to show here a clinical case about a particular localization for a tumor. Let's start. Many times in clinical medicine, we look at the patient, but we really don't see specifically in some type of persons. For instance, women is not uncommon to get a bias with a cardiovascular problem. With immigrants, they have new languages, new diseases. With elderly people, usually they have more mild symptoms in general. Disabled people in clinical medicine still we had to recognize some prejudice, and it's difficult sometimes to interact with the family. And also there is some special population, psychiatric patient, where the diagnosis usually is biased and the obtention of the information is very difficult. Let's suppose here the case of a 24-year-old male with paralysis after postpartum anoxia. He was diagnosed with schizophrenia and he was taking several drugs and tranquilizer. 2 months before the definitive diagnosis that we are exposing now, he began to feel weak and asthenic without fever and less appetite. He went to a general practitioner at least twice, and no pathological letters were detected in the physical examination in a crowded, usual clinical room. A week before the definitive diagnosis, he began to experience abdominal pain and nausea, and the family had an insistence to make a CT scan from the abdomen and pelvis. This CT scan was made, and it showed some lymphadenopathy in the retroperitoneal area. A directed physical examination showed the presence of a left testicular mass, and an inguinal orchiectomy was performed with the definitive diagnosis of a malignant tumor, seminoma type. In this case, there was a delay in the diagnosis. We can divide the origin or the probable origin of this delay in a cognitive aspect, as usual, and systemic aspect. On the cognitive side, usually we in clinical medicine, we have some prejudice and that can bias our clinical reasoning. And we get also some availability bias. That means that the first idea that comes to your mind in a boy with, in a young man with abdominal pain, you think usually in another other question if you don't direct your clinical examination, your physical examination to specific areas. And of course, there are some labels of prejudice that we put in some special population of patients. And talking about the systemic side, usually the general practitioners' clinical practice are very crowded. There is a work overload, and there is not really a particular space for a proper diagnosis because there are a mix of different clinical problems, some important, some not important, and is not less important the amount of office work the doctor, a GP doctor, has to make usually during the a day in the clinic. If we see in an information, we see that young people with this age, around 20, male young person, well, the most common tumor in this period of age is thyroid, testicular cancer, and lymphoma. Then, when we had to think and we had to know this situation to try to direct our physical examination to localize this part to examine also the complete body, directed specifically to the testis area, to the testicular area. In conclusion, placing labels, sometimes with a special population, or having prior judgment about the patient can alter our clinical reasoning and lead to a diagnosis error. The clinical method, even if it's directed according to symptoms, must include a history of physical examination. And it's important not to forget certain anatomical sites that I call dark places, retroperitoneal, genital area, even the skull, that are not generally and usually inspected. Thank you very much, and I hope this could be useful for people in general and for our clinical practice. Thank you so much.